at this point of time, sir. And so what was done is, yes, utilized visco and, clear cortical wash was done.
Yes, your video is not seen. If you want to.
The video is being seen, sir. And the lens was tried to put into the sulcus. The main surgeon wanted to do it, themselves, but unfortunately the IOL entered into the PC tear. Am I audible? Yeah. So the IOL entered into the PC tear, and then we noticed a vitreous loss there. So that's when I entered, and then I removed the IOL. Removing it, it was stuck in the PC tear, so it was not an easy job. And vitreous loss was noted. That is when the IOL was removed, and then an open sky anti-vitrectomy was done. So this is what you're seeing, that IOL was removed, the vitreous loss was seen. My vitrectomy probe was not working that particular day, so I went ahead and then did an anterior vitrectomy with Vanas. The video is played very fast, so it is not that speed that I have tried to, pull the vitreous in. It looks very scary when you see that thing happening there. So once I was sure that, okay, the vitreous is all gone, that is when I decided to place the IOL in the sulcus. I had a good rim of anterior capsule there, so the IOL was placed in the sulcus. What should be noted is the angulation with which we put the IOL is what makes it, go exactly in the sulcus. Earlier, there was a angulation which made the IOL go into the bag. So the carpinol was used to make sure that, the vitreous is not there, but yes, there was vitreous there. So the vitreous is, again, we continue with the anterior vitrectomy. And finally, an intracameral tripod was used so that to confirm that there is no vitreous there. Round pupil does not mean that there is no vitreous in the anterior chamber. Yes, I could see that there was a strand which was, going towards the side port, and then cut that anterior, the whatever vitreous was there in the side port, and then AC was formed. The patient is still 1 month post-op, 624 uncorrected vision as of now, no corneal edema, no corneal decompensation, and cylindrical power of plus 1.5 was noted. Thank you, sir.
I think Dr. Shilpa, you can just comment.
Hello.
Dr. Ravi.
Yes, sir.
Dr. Ravi, you can comment on it.
And who is answering for this? I think Dr. Shilpa, I think, no?
No, Ravi.
No, sir. No, sir.
Ravi, okay.
Okay. Chetan.
Yeah.
Finally, it looks very nice and round people. Everything is okay. But when it was noticed that rent?
The rent was noticed when the wash was being given from the side port. See, usually entire wash has to be given from the side port, and what is under the side port, we should utilize the main port to remove. But this particular surgeon used the side port to remove the cortex under the side port, where I could actually spot a stress line on the PC, and then saw a linear PC tear also. Okay, and then it could have been managed well without vitreous loss if directly an IOL was placed in the sulcus. But unfortunately, we did have a vitreous loss, and this is how I could manage at my center this time. So I'm open to suggestions how best it could be managed otherwise.
It could have been prevented if it would have gone from the main port, you mean to say?
Yes, because everything went on well, Ravi. No problem with nucleus delivery, no problem with cortical wash also to an extent. If you see the video, while trying to remove the cortex under the side port, No, that angulation, what was given, hit the PC and there was a tear, a linear tear.
In the video, it is not clear what was the size of the rexis. Was it smaller in this case?
No, it was a big rexis. Rexis was around 6.5 millimeters.
Then after a pupil constriction, you could put the lens in the sulcus. No? You
Yes.
could not visualize rexis margin.
Yes. So my point was triamcinolone acetate. Could I have used it earlier or
Earlier, yes. I feel it should have been used earlier.
Okay.
And also at the end to confirm it, diluted. And second thing is vitrectomy manual. No manual vitrectomy. You should have everything prepared. That's what we were talking last time. And other things are fine, I think.
I did not do a PI here.
PI also was not done.
I should have done a PI or not. I mean, after I closed the case, I thought the PI must have been done.
PI should be done when there is a vitreous loss.
Okay.
Not necessarily.
Okay. Thank you, Ravi. Thank you so much.
Thank you. Thank you.
Thank you.
Dr. Sushil, are you ready? Dr. Sushil, can I present
Yes,
your?
sir. Yes, sir.
He has given voiceover. Please let me know if the voice is audible or not. In the meanwhile, I think I request a lot of questions for these cases. We'll answer all of them. Please keep them ready. What better could have been done for each of these cases? We'll have the question and answer session at the end of all the presentations. So please keep all your questions ready here.
Everyone, I'm Dr. Sushil Kakanki. I'll be showing some of my videos on a posterior capsular tear. Posterior capsular tear is one such complication that makes us sleepless nights, and the consequences of a posterior capsular tear, mainly lens drop, or it may be a decentered IOL, it may be a prolonged inflammation, or it may be a cystoid macular edema, or retinal detachment complications, and so on. These will start coming into our dreams, and that makes us sleepless nights for so many days after the posterior capsular tear has occurred in one case. So it is very important for us to understand the cause of the posterior capsular tear, so that the essential basic steps can be taken to prevent a posterior capsular tear. Prevention is the best form of management, and assessing the predisposing factors play an important role in preventing a posterior capsular tear. So there are so many predisposing factors that can lead to a posterior capsular tear, and according to me, the first thing which I focus is on a microscope. So when focusing on the where the focusing on the oculus is very important, and the second most important thing is your IPD settings, so that for a beginners, this diplopia, improper IPD settings will always lead to a posterior capsular tear. And sitting on an operating chair is comfortably is very important. And the second most important thing I feel is extraocular ergonomics. It is very important to have an operating eye to be placed horizontally, and we have to be very cautious if it is a deep set eyeball with a narrow palpebral fissure, and extra care to be taken about the speculum, because in such cases what happens is unknowingly the speculum will be pressing upon the globe. That itself is a predisposing factor for a posterior capsular tear. So there are so many other factors that can lead to a tear. It may be a small pupil where the visibility is less, or it may be a shallow anterior chamber where the chances of your instruments hitting the posterior capsular tear is very common, or it may be a thin posterior capsule, especially in cases of a hard cataract, because of overstretching of the capsular bag, because of large volume, that makes a predisposing factors. But in my cases, or in many of my cases, the posterior capsular tear has occurred during a cortical wash. Is it important for us to recognize the stability of the posterior capsule before you implant the lens? Yes, it is very important for us to assess the stability. In this case, you can see I was just focusing on the anterior capsular rim, and you can see what happened in this case. So the PC tear was unnoticed. It was because of pupillary constriction, and the PC tear gave a way for a lens drop. I don't know in which step the PC tear occurred, but I ended up with a nucleus drop in this case. In such situation, for solo practitioners, it becomes very difficult to explain the patient about the further management. The two cases which I'm going to show where I ended up with a posterior capsular tear was during a cortical wash. In both the cases, probably during a cortical wash through a main wound, I pressed upon the posterior lip of the wound, and the posterior capsule came up, and my cannula pressed on the capsule, giving a way for a capsular tear. In the first case, I did a manual vitrectomy after injecting a triamcinolone, and iris claw lens was placed in the first case. And the same thing happened in a second case during a cortical wash, and again my cannula pressed on the posterior capsule, giving a way to the capsular tear. And in the second case, I placed the lens in the sulcus. There was no vitreous disturbance in the second case.
I think the discussant can now start commenting.
Yes, beautiful videos, Sushil. Just wanted to know, in the first case, when did the PCR happen? Because I could not see the rhexis rim, and I thought there was no bag. Because vitreous face was not disturbed, you would have placed it on the anti-vitreous face, and once you were in with irrigation on, the lens sagged down. Was it like that?
Sushil, you're muted.
Yes, ma'am. Actually, I was like, because the pupil was constricted, I was just focusing on the capsule, whether the bag is there or not. I was just focusing on that. So once I saw my capsular rim, I was so happy that nothing will happen. I was not aware of that rent also, and I didn't notice any rent. So once I placed the rent, it was quite stable, and when my Simcoe cannula entered inside, suddenly it didn't give me any time to catch the lens also. Suddenly it dipped into the vitreous cavity.
So that means it was a huge PCR. Okay, and then in the second case, that happened because of you were doing it through the main port.
Main
So
wound.
usually,
Probably I pressed upon the posterior lip. Probably that has the tip of my cannula might have hit the posterior capsule, madam.
exactly, because our small incision cataract surgery wounds are pretty longer as compared to phaco wounds. It's always advisable to do it through the side ports, so that
Yes.
your visco is not leaking and your PC is not up into the when you're opening the main wound, it's upthrust. So
Yes,
that is one way we should always keep in mind, not to
and
have
in
PCR.
second case, it was quite deep set eyeball. the maneuvering was quite difficult in the second case. Probably a deep set eyeball and going through a main wound. They were all predisposing factors for my tear.
True, very true. So, in such cases, what we teach our students is whenever you have a tendency of shallowing of the AC or some unusual globes, there you go in with visco in all the time so that your AC is not collapsed totally once you open the main wound. With a minimal irrigation, you can just do the cortical aspiration. That is one trick you can always follow, or inject visco and do just dry aspiration of cortex as in when we do it in cases of pre-existing PCRs or traumatic cataracts. That can be a trick where you think you are anticipating that this case can have a PCR.
Yes, ma'am.
Yeah. Other discussants also can chip in. Deepak sir.
I think we'll have the same question. Scissor vitrectomy. I don't think it's it's advisable at this stage. I call it a
Yeah.
scissor vitrectomy, not an open sky now, because I think we'll have a question answer session on
Sir,
purely
actually,
that.
usually what happens is, usually I do a regular vitrectomy with a phaco machine, like the vitrectomy with phaco machine. Usually if the phaco is not connected, it becomes very difficult because usually we don't have a separate vitrectomy machine to do a vitrectomy if we are doing a CAM cases or a charity cases. So for if the phaco is connected, it becomes very easy for us to do a vitrectomy.
I think the take home message of this seminar would be like, there's nothing like a camp case or a paying case or a charity case. Every eye is precious, and we need to follow the same dictum which we follow for a paid patient. There's no excuse for not doing this. So once we think that cataract surgery is done, I don't think they don't see there is any excuse for not having a vitrectomy unit ready there. I think we'll have a
Absolutely.
discussion at the end regarding this.
Correct.
And regarding the IOL placement, regarding in the first case where you put the lens inside, as well as for Chetan's case, see, when you're not able to see the anterocapsular margin, I think it's very risky to put the IOL there because you don't know. The best would be spend extra 10 minutes to put the iris hooks, dilate the pupil. See, surgery, the basic concept of surgery is to see well. If you see well, you can do well. So if you can retract the iris and see, locate the anterocapsular margin and then place the lens, it won't drop. But in your case, you are confident that the PC tear was not there. So that's a different argument here. But general rule of the thumb would be like, you want to ensure that you're seeing well always. Okay, that should be the take home message. And thank you for all the wonderful case collection which you have showed. There are so many variants of all these cases which you have seen. And I'm sure every one of us would have gone through these stages. It's a wonderful collection. Keep it going, Sushil. We're proud of you. Okay.
Don't keep it going. Don't do complications, sir.
Keep collecting the cases.
Keep collecting this.
Yes. Okay. Can I go to the next presentation?
Hello.
Yes, sir.
Okay, I'll be sharing my presentation. It would be like, is it possible for us to prevent vitreous from prolapsing in the event of a PC tear? That is the idea which I'd like to present here. This is a young male, classical posterior polar cataract, and the nucleus has been managed. I'll begin from this stage. At this stage, I'm not sure that the PC tear has happened, but I am suspecting that it could be there already. Now we have an epinucleus layer and a cortex which is there inside. So I'm using dispersive OVD to do some visco dissection to just pull out maneuver the epinucleus out gently out. The nucleus is out here, and it is quite tricky to remove this epinucleus, soft epinucleus and cortex here. So I'm using my bimanual to just engage it and remove. The whole trick is you need to be as gentle as possible in these cases, because I'm assuming that there is a posterior capsular tear already, although it's not very clear here. I can see some line here, this line, and I'm suspecting that there is an underlying postcapsular tear here. So my goal is at this stage to prevent any rupture of the anterior hyaloid face. And one trick which I always use is to lower the bottle height. The bottle height which I'm using is 60 centimeters, contrary to one which we regularly use is around 90 to 100 centimeters. So you are going slow, and to compensate for that, I'm also using less flow rate and less vacuum. I don't want the chamber to shallow, but also I don't want it to suddenly deepen, especially in young patients who have got this elastic sclera, and the eye has a great tendency to suddenly deepen and also shallow. And you can see now it is clear that a vertical through and through split is seen in the posterior capsule, extending from this end to that end. So before removing, again, we don't want the chamber to collapse. So I'm using viscoelastic agent to just form the chamber a little bit. Again, inject just a little bit. You don't want it to be too much here. And then again, switch hands and complete it. Again, you need to be, I think the only secret to achieve this, you need to give a lot of time. There is no hurry. Only thing you need to tell is you got all the time in the world here. Okay, you may have another 10 cases waiting for you, but this case deserves every bit of attention and time. Skill is not so much required. You just have to develop the right attitude, and the bottle height is dynamic. As soon as you see that the chamber is slightly fluttering and shallowing, you can always ask your assistant to just increase it a little bit. And I'm able to see the rent now through and through, and this small bit of cortex is still there. A point to note here is, please note the shape of the postcapsular tear. It is just a vertical split. It's not widened. If it is widened, then it's a surefire indicator that the vitreous is already prolapsed. So that is one clear-cut indication that still the anterior hyaloid phase is still intact. Okay, again, you don't want the chamber to shallow. Inject viscoelastic and come out. And now I'm trying to form the chamber. I'm using first dispersive OVD, and then I'm also using cohesive OVD to deepen the bag here. Again, I'm always keeping a look at the shape of this postcapsular tear. It is linear and it's not spread wide open. And the hydrophobic single piece lens is open very gently. The haptic is ensure that it opens in this area, not in this area, so that I don't disturb this area. And removing the OVD behind the lens is very tricky here. And as you can see, I'm lifting the lens and gently irrigating. The bottle light is about 30 centimeters now. And you just wait for 2 minutes. Every viscoelastic can be removed out. And one final confirmation with time state ensures that, we're sure that the vitreous is not disturbed here. So even in spite of a postcapsular tear, we could achieve a situation where, anterior was not disturbed. Now, moving on to the next case here. This is, again, a very young patient. This, I'm not thinking that it's a polar cataract. Everything was looking fine. It was just a routine case. So I did not make anything special here. The cortex is being aspirated. The nucleus was removed, soft nucleus was removed. And the cortex is being aspirated. So far, so good. There is no postcapsular tear at this stage. And now I'm just filling the OVD into the bag, and then I have to just place the lens inside. That's all I have to do. And what I'm doing, I'm injecting viscoelastic and then go back and load the lens here. And a surprise is awaiting me before I implant the lens. Now, lo and behold, no, the PC was perfectly fine. I injected viscoelastic. Now you can see the vertically split posterior capsule here, again, equator to equator. The way this splits is usually classical of a polar cataract. And this was extremely, surprising for me. You never take anything for granted. What happened, the posterior capsule was all right all through. The amount of OVD which I injected into the bag was far more than what the weak posterior capsule could take. You can see I'm just using a little bit more OVD. That itself was responsible to just split the capsular posterior capsule. Now, in this case, again, the anterior hyaloid still is intact. I was very sure about it. And again, I'm using the same designated single piece lens which was scheduled for this patient. I placed the lens into the bag with the haptics oriented away. Again, with a low bottle height and extremely low flow rate and vacuum, I could remove every bit of visco which is in front and behind the lens as well. Again, the message would be, it will take some time. It will take another 5 to 10 minutes extra to just carefully irrigate out and aspirate out all the OVD which is there, but it is possible. So, it's not necessary for you to leave the OVD. Maybe you can just leave a little bit. But if you're careful, most of the OVD can be gently removed out. And even, you can aspirate the cortex, which I showed in the previous case, even with a low bottle height. You don't have to have a dry aspiration always. Again, before closing, I do confirm with diluted triamcinolone acetate, and then the case was done. So this was a case where we had an equator to equator, prolapse of the rupture of the posterior capsule, but still we could manage to place the intraocular lens into the bag itself, and eventually it went. So the take-home message here would be posterior capsular tear and anterior haloid rupture are two independent events. It's not necessary that if you rupture a posterior capsule, you will always rupture anterior haloid. The key is early detection of PC tear. If you're able to identify, diagnose the posterior capsular tear early enough, then you have got enough opportunity to ensure that the anterior haloid is not ruptured. So in at least 50% of your posterior capsular tear ruptures, if you're very keen and very alert to the situation, you will be successful in preventing the anterior haloid rupture. And dispersive OVD, which contains of chondroitin sulfate, viscoat or viscoat-like, is a great OVD to have in this case because it acts like a barrier. Once you have a PC tear, inject it underneath it. It acts like a barrier and prevents percolation of the fluid into the behind the posterior capsule. And low bottle height is again extremely critical. If you increase the infusion pressure, the pressure itself is going to blow out, increase the posterior capsular tear size as well as rupture anterior haloid phase. I think that's it. Thank you for your attention. We can take the question answer sessions at the end.
Next would be
Can we move on to the next presentation?
Yeah. My top tips for managing PC tear by Dr. M.S. Ravindra sir.
Yeah, I think we've seen some wonderful videos and wonderful comments, and I think it's mind-boggling videos again, Dr. Deepak. So I'm going to just analyze few. I'll share my screen. I'll show you. Few videos. I've had a large, I'm operating from the temporal quadrant here, sclerocorneal tunnel. Am I audible?
Yes, sir.
Fine. So sclerocorneal tunnel, I passed it. And then now you can see the tear, which is ballooning towards this convex towards my left. Can you see? That's a tear there. And now whenever it's pushing this side, that means though you can't see the vitreous there, you can presume that vitreous has crossed the boundary of the capsule and is migrating into the pupillary zone and maybe into this thing. What I do is this is the irrigation cannula, which is 25 or I would use rather a 22 gauge cannula here, 22 or 23 gauge cannula, which is continuously irrigating infusion. Is a planned, capsular rupture, unplanned capsular rupture. So I have not put any irrigating ports into the eye. On the left side of my sclerocorneal, I hold this cannula and it's attached to a bulb which continuously infuses. The amount of infusion is proportional to what exactly is needed. So I've taken a 23 gauge port and that starts doing vitrectomy. I will not start doing vitrectomy here. If there is vitreous in the tunnel already, I'll clear the vitreous that has come out here. Obviously, the vitreous is limited to the pupillary space here, pupillary plane. And I just go there and just in the plane of pupil, I'm doing the vitrectomy. I've just come out. I would not like to remove the cortex using the vitrectomy probe for various reasons. I would always like to take back my Simcoe cannula, as you can see here. So there is some cortex which is hidden under the pupil. And then you can see observe the capsule as it flutters there. That means vitreous is still coming out. Once if posterior capsule is flat there, that means vitreous has gone behind this plane. Now there is some cortex underneath the iris proximal to, now you can see here the capsular bag has, capsular tear has nicely gone behind. That means all the herniation has been removed. You can have the iris claw, the pupillary retractors, or you can use a wide dialer as I'm doing it here. Inspect the entire, it's very important to remove the entire cortex from the eye before you do it. Now I'm inspecting all the corners just to see if there is any cortex hidden anywhere. It's very important to remove. Here I prefer to do iris claw lens, as you can see here. I'll go fast here. That's not my intention to show the iris claw lens. I do examine it by injecting some amount of triamcinolone, which is diluted 1:1, and there's no vitreous fibrils, and that's the end of surgery. Let me just show you the second case. Here, I've already noted that there is a large zonular dialysis in this hypermature cataract. I've bisected the nucleus. I'm very carefully removing the nucleus. I would have enlarged the tunnel in such situation to avoid, damage to the endothelium. And now you can see the entire capsular bag herniating now. My main intention at this point of time is to avoid cortex or epinucleus and nucleus dropping backward. So I will not deepen the chamber too heavily. Just enough viscoelastic is used so that these pieces should not go inside into the vitreous cavity. This cannula is injecting visco continuously into the anterior chamber. I'm just opening the tunnel and guiding the nucleus to come outside, the part of epinucleus. I'm injecting in front of it so it doesn't rub the. So you can see much of it has come out. Very carefully, there's no irrigation. It's almost like dry aspiration. It's almost like dry aspiration. Very little quantity of fluid is to be injected. The amount of fluid that goes inside is controlled. AC is kept not very deep. Deeper the AC I do, these chances of pushing these into the vitreous cavity is very high. And when I've asked for the vitrectomy probe, in the meantime, whatever vitreous that has come outside, I'm just removing it with the scissors, vitrectomy, whatever you call it. And the vitreous that has come outside, you can always trim it. I'm preparing myself to put the iris claw lens here. Very gently. You can see, in spite of the vitreous being there, and if it's not admixed with cortex, you can always do a limited vitrectomy and guide these things to float out of the eye. I formed the chamber. So you can see the people eccentric here, people dragged out there. There is an amount of vitreous in that area, as you can see here. You can see the capsular tear. I'm doing a vitrectomy, very limited vitrectomy, infusion with my left hand, and vitrectomy with the port down, facing down towards the vitreous. I'm just picking up the fibrils of vitreous, as you can see here. There is a lot of vitreous herniation there into the angle region. This has to be done very carefully, because when you're pulling something vitreous loop into the anterior chamber, you're also dragging the vitreous base and the peripheral retina. So this has to be very gentle, because the loop outside of the loop is not adherent to anything. It doesn't matter. I'm doing a small vitrectomy, small iridectomy there with probe. Then I'm